Ooh, 20 attending. Very nice.
Thank you, Vanya.
Okay.
Good turnout. I like it.
Now I might just Harlan, aren't you going to have tea?
Yeah, he's going. So, what's going on in your backpage?
رايح صح؟
I'll just give a couple more minutes and we'll get started.
Anton, you're the best.
Oh.
Okay, I think we should get started. Thank you everyone for joining us. We have a really great speaker today. This will be our fourth lecture as part of the Southwestern Ontario Critical Care Series, or SWOCCS, as we're trying to call it. Just as a quick reminder, this is a series that we're trying to bring, CME activities that are topical to the area. We're trying to increase collaboration amongst the critical care group down in this region, as well as sharing maybe some common stories amongst the critical care groups. And as a reminder, we are still waiting to have some of our other sites outside of LHSC present some cases that they've seen. And we are open to hearing anyone. We have a very special presentation today. So Dr. Eric Walser will be helping out. He is a general surgeon with a particular trauma interest, but our main speaker will be Dr. Kelly Vogt. Now, Dr. Vogt received her medical degree and general surgery residency training at Schulich School of Medicine and Dentistry at Western University. During her residency training, she completed a Master of Science in Health Research Methodology from McMaster University. She went on to complete a fellowship at LA County, University of Southern California, Medical Center in Trauma and Acute Care Surgery. She continued on as a clinical instructor before returning to Victoria Hospital, London in September 2014. And she has continued as a clinical scientist and is the trauma director for London Health Sciences. Her research focuses on clinical trials in acute care surgery and trauma, and she has been a close mentor for both myself and Dr. Walser, and we are very excited to have her here.
Thanks so much for inviting me and really for the opportunity to speak. And I can't thank you enough for the work you've done on behalf of the trauma program this year, Anton, and the short time you've been with us, and to Eric Walser for being part of this presentation with me, and really for the opportunity to just chat with you guys about trauma. Those of you who know me know it is my passion, so I'm always really happy to share. So thanks again for the opportunity. Neither Eric nor I have any disclosures. Just a quick outline. We are hoping to provide you with a brief overview of the trauma system, as brief as we possibly can. It can be confusing. And then Eric's going to provide a little bit of detail with my flavor injected on some of the more kind of controversial or up-to-date topics, or the things that you're likely to see if you are outside of London Health Sciences Centre caring for trauma patients or one of the other lead trauma hospitals. And Anton's going to moderate the chat, so we hope to engage in conversation. Please feel free to ask questions. So I think starting at the beginning, I think is quite important. And when we think about trauma, I think the concept of a trauma system is really of critical importance. And what this speaks to is the concept of regionalization of trauma care. We know that patients from years of data that patients who suffer multi-system severe trauma achieve optimal outcomes when they're cared for in centers with experience and expertise in severe trauma. That being said, it's really important to acknowledge that it's about more than just the hub and spoke model with a lead trauma hospital in the center and referring hospitals that are kind of injecting patients into that system. And then sometime down the road, those patients go back maybe for some convalescence closer to home. The system is about that for sure, but it's also about the integration of pre-hospital and transport. It's about really important activities in injury prevention, education, and communication. And those things can't be underscored when we think about how we care for trauma patients in Southwestern Ontario. So more specifically to our region, we do have 2 lead trauma hospitals in our region. Those are the one here in London at Victoria Hospital and one in Windsor at the Ouellette campus. The designation of level 1 that you see there really refers to an American system of trauma verification. But essentially what that equivalent means is that these centers have the organization and resources to care for the most severely injured trauma patients. It also means that there are other structures in place to be leaders in the trauma system. And those are particularly around educational mandates for things like advanced trauma life support training, and also things like research and quality improvement deliverables, and an important role in the broader provincial trauma system, where we're sharing information with our colleagues from the other lead trauma hospitals in the province of Ontario. Maybe a flip to the next slide there. Perfect. And the interface with our specific lead trauma hospital occurs through our the trauma team leaders at LHSC are physicians with varying backgrounds, all have advanced training in one form or another in the initial evaluation and management of trauma patients, and also probably, and I say to them often, more importantly, an understanding of how the system works and functions, because as we start taking trauma team leader call, those phone calls you get about the sick patient who is snowbound in Lion's Head with a femur fracture, but you have to decide if the police should clear the road for them to come and risk the car crash. Those are the things that I think become more challenging as a trauma team leader. And that was my first weekend on trauma team leader call in the winter when I came back on staff. So those are very stressful experiences. As you guys are all likely aware, all of our trauma transfers are facilitated through Critical. Back when we had one number, we did not participate in that system for various reasons. I think also relevant to acknowledge to this group is that we do not have a burn center in Southwestern Ontario, but that does not mean we don't care for burn patients. We will manage burn patients. It's a moving target with 25 to 30% TBSA burns, depending on which plastic surgeon is on. But what we do specialize in is providing stabilization and the early and initial immediate treatment of burns. So that's an important conversation if we're thinking about initial trauma patients. And this slide really, the beautiful orange helicopter, but really speaks to the importance of how do patients get here. And we're going to talk a little bit more about that. But I think as we talk about the trauma system, one of the key pieces we've discussed is the importance of not only the pre-hospital environment, but also the communication. And so there are a set of field trauma triage standards that allow bypass of certain trauma patients who are severely injured to our lead trauma hospital. And those are largely based on physiologic criteria combined with a mechanism of injury that's severe enough. But what's a little bit unique to trauma in the setting of these regionalized trauma care models is that the sickest of the sick patients actually don't apply. And so for all of our referring hospitals that are on the call or that we interact with, as one of my favorite parts of my job, you need to be prepared to receive those very, very sick patients and provide their initial management in a hospital that really isn't designated as a trauma center at all. And so we're going to talk a little bit about that today, and then a bit more about the patients that stay in your centers because they don't necessarily meet the criteria for immediate transfer to a trauma center. So I'll turn it over to Eric to talk a little bit about the medicine components now, but you'll hear lots from me too.
Thanks so much, Dr. Vogt. So I think we really wanted to focus this on things that we think are relevant and important, but also things that are that critical care providers may find themselves in. We recognize that most of the patients who come into peripheral trauma centers are dealt with mainly in eMERGE. As TTLs, myself, Anton, Dr. Vogt, we take most of the calls from emerge physicians, and many patients go direct out of those centers without doing that. But for a variety of reasons, because someone's super sick and it's all hands on deck, because they're having a prolonged state of some of the transport issues we talked about. I think that critical care providers are getting involved in these patients, and it's important to have a recognition of some of the principles at play, focusing on the things that are different than the average patient that you have, because there are some things that are different from the resuscitation of the average critical care patient, and even sometimes the average bleeding critical care patient that we're all used to taking care of. So I want to talk a little bit about how we can resequence trauma resuscitation, some specifics around fluid management and hemostatic support, and then really delve into when to transfer, how to transfer, and those patients who may end up staying in your institution that you're going to care for a whole variety of reasons. Most of us will have, as part of our training, taken ATLS or some other form of training, and that really focuses on airway, breathing, circulation as the cornerstone of trauma care. And that's been challenged recently. The reality is that ABC of ATLS was initially based almost entirely on expert opinion. And there's more and more retrospective evidence showing that there can be a lot of harm for tackling someone's airway before their circulation in bleeding trauma patients. And this makes sense. Positive pressure ventilation doesn't treat hypovolemia. We talk about causes of shock and trauma, and when we teach this to junior residents, we talk about hemorrhage, something else. And so the bleeding, catastrophically injured patient does not benefit from having an airway put in place if they don't have an airway problem. The caveats is that a lot of this data that talks about resequencing resuscitation is American data. There's a lot of penetrating trauma in those circumstances, and there's different airway concerns in penetrating versus blunt trauma. Our experience is almost entirely blunt. And then the other thing is that all the data that this is based off of lead trauma center data, and my ability in our trauma bay in London to not intubate someone or to resequence trauma with a bunch of providers, a bunch of blood, and really good hemostatic interventional support is different. But we're going to try and talk through how this affects people. And I think the biggest thing is just thinking about that treating catastrophic hemorrhage should be your first priority. So CCAB is the model. And I think that the things that have made a really big difference have been the use of tourniquet, the use of direct pressure and packing to control external hemorrhage. A lot of that research came out of Afghanistan and Iraq and has been super influential. And then remembering the common phrase of resuscitate before you intubate. And so immediately moving ahead with intubation before obtaining large bore IV access or starting blood or fluid or whatever you have, I think is really important, and then allows you to go into that airway management scenario that'll likely be difficult, prepared for success. There's a really good editorial on this in JAMA Surgery from Paula Ferrata and Sharmila Tasanki, who are two excellent trauma surgeons in the US, that if anyone is interested in reading more about that. So hopefully you've done some resuscitation, and I would say in general, most people on the call are comfortable with airway management, and I would say the principles of airway management in a trauma patient are no different than the principles of airway management in a non-trauma patient. But there are some specific caveats, and there's actually a guideline from the Western Trauma Association on this, so I'll highlight some of the points I think are important. One of the things is that often now, as our pre-hospital providers get better and better, they're placing advanced rescue airways. They're placing LMAs, they're placing eye gels, they're placing a variety of other commercial products. And one of their recommendations is, if that's working well, that shouldn't be removed until the patient is doing well. And they sort of advise at the completion of the secondary survey. But the key is to not remove it sort of as a reflex. If the shock index, so the heart rate is greater than, if the shock index, which is the heart rate divided by the systolic blood pressure, is greater than 0.8, they say you should really consider the need for simultaneous maneuvers. And that can be chest tube placement if you think the patient has a tension pneumothorax, blood transfusion, or push dose pressors. The preferred agents for induction are ketamine or etomidate. You can tell it's an American guideline because there's a heavy emphasis on etomidate. But one of the really key points, and I think a lot of us do this in our day-to-day practice, is to dose reduce that sedative or that anesthetic agent by 50% if the patient is unwell. And then they recommend rocuronium or succinylcholine for every patient. I think a lot of us in London use rocuronium almost exclusively. And again, when someone's cardiac output is low, you want to achieve the best intubating conditions as soon as you can. So increasing that dose of rocuronium in sick patients and decreasing your dose of ketamine or etomidate is advised. And the last thing is that video laryngoscopy is the preferred route, especially given the need for C-spine precautions. I think there's been some trials recently that have moved a lot of us towards using VL routinely, but especially in a patient in C-spine precautions, video laryngoscopy gives you a pretty significant advantage. With respect to fluid management, I think the ideal fluid for bleeding trauma patients is blood. Interesting work coming out of the US and out of Afghanistan and Iraq shows that whole blood is likely superior, but the reality is it's not available in Canada, even in most lead trauma centers. 1:1:1 balanced transfusion is likely superior to ratios with more packed red blood cells, and I think a lot of us in the trauma community really believe strongly in this. And then one of the things that's been fairly well demonstrated is that more than a liter of crystalloid, Bringer's lactate or normal saline, prior to obtaining hemostasis with the surgical or IR procedure is associated with worse coagulopathy and worse outcomes in a variety of ways. And we'll talk a little bit how to actuate that, because I recognize that that's more challenging depending on where you are. Then the last thing is that a variety of guidelines have started to recommend permissive hypotension for actively bleeding patients. This is the idea that if someone has a normal blood pressure, they may bleed more than someone who's appropriately hypotensive when they're severely hypovolemic. And the recommendations, and this is based off of one of the European guidelines, is that a systolic blood pressure of 80 to 90 is reasonable, or a MAP of 50 to 60. I think another really good way to do this that I use a lot is if the patient is talking and has a reasonable neurostatus, then that's appropriate. One of the big caveats is that anyone with suspected TBI, this has not been evaluated and is not considered safe. So in those patients, you want to target a normal blood pressure. And I know Kelly has something to say about this as well.
Yes, I do. So thanks for all that, Eric. And I mean, I think you can't give a talk about initial resuscitation of trauma patients without talking about this concept of permissive hypotension. There's so much conversation that occurs in the trauma circles about it. What I think is really key about that, though, is acknowledging that the studies that looked at permissive hypotension occurred in lead trauma hospitals, and the concept of permissive hypotension was a transient concept en route to the operating room until you could get surgical hemorrhage control. And so I think that as we're talking about patients who are in centers that are not immediately going to the operating room, we'll talk a little bit later about centers where you might actually go to the operating room. This is generally a concept that should not be actively explored outside of the patient who's on their way to the operating room. The idea that you want to aim for a systolic blood pressure of 130 is probably also not accurate, but aiming to or actively withholding things so that patient's systolic blood pressure is within the permissive hypotension range is probably not something you want to do unless you have ready access to a surgeon in an operating room to get definitive hemorrhage control.
Awesome, thanks. And so this is some of the data that talks about crystalloid being bad for patients and being associated with increased mortality and worse outcomes. And then this is the proper trial, which is kind of the landmark trial that we think showed that 1:1:1, where higher levels of plasma on FFP is better than 1:1:2. The interesting thing is this was a negative trial according to their primary outcome, but less patients died from bleeding and more patients got hemostasis in the 1:1:1 group. And that works really well in London, where we have a blood bank that looks sort of like this. But in making this talk, we really wanted to recognize that the reality is that there's a lot of centers in Southwestern Ontario where their blood bank maybe isn't 2 units of O blood, but they don't have the same resources that we have. And so I think we'll go through some of the recommendations about kind of what can be done in those centers. And there's not great evidence to guide us in this scenario, but this is something that we think is sort of reasonable and appropriate. I think oh, sorry, go ahead.
Oh, no, that's okay. Is that okay, Eric?
Yeah, go ahead.
You know, my strategy in conversation with individuals who are looking to send patients to us where there's a suspicion of bleeding is always quite similar. First, and not on this slide, if the patient is on anticoagulation, reverse the anticoagulation if you can, and we'll hammer that point a little bit more later. Use what you have in terms of blood products, though. Acknowledging that you never know what's going to come through the door behind you. If you have access to RBCs, which every center does, start there. If you have access to plasma, which most centers do, use that. Fibrinogen concentrate, if that's available to you. And I know that in many centers, platelets come from elsewhere. So, you know, that may not be something that you can easily action. But when you do have blood, you should use the blood. as soon as you possibly can. And then if possible, if you can get to a setting where you don't need to continue transfusion, minimalizing the crystalloids as much as possible is the ideal status. And that's just where we kind of differ from what we would teach our trainees here in the lead trauma hospital. There is probably a role for vasopressors in the circumstance where you're limited in your blood product availability. In terms of evidence, certainly vasopressin does have the best evidence. I think that practically what we often see is norepinephrine, which I think is also a reasonable choice. Do the best you can, and why we, would argue use all the blood that you have kind of first or in conjunction with the vasopressors, is you're not going to improve your blood pressure if the pump is empty. But if you're able to fill at least partially the tank, then this is a reasonable adjunct in the patient that's looking to be transferred to the trauma hospital.
And I sort of struggle to give any talk about trauma and fluid and resuscitation without just briefly discussing what sort of the best way to transfuse and resuscitate these patients are. And the reality is that blood flow is a function of radius to the power of 4. And so peripheral IVs most of the time are your good friend in this scenario. If you have the ability to place a cordis quickly, or an introducer sheath, or some other sort of massive transfusion central line, I think that's a reasonable approach. But we're going to talk a little bit about transfer and the need to get these patients out. And it's really, you have to work pretty hard to out transfuse a good 16 or 18 gauge IV hooked up to some form of rapid transfusion. In terms of hemostatic support, I think that, we'll talk a little bit about patients who maybe can have surgery elsewhere and then come here, or what you can do. But these are the things that you can do as the intensivist or the person taking care of this patient to help, because these things have been shown to associate with less blood loss and better hemostasis. And so I think probably starting with the easiest thing that everyone can do is really minimize hypothermia. And this is a problem in Canada because it's cold for 6 or 8 months out of the year, but this can be a problem on a sunny July evening. These patients come in hypothermic, and then we do things to them to make them hypothermic. We give them fluid that's not warm. We take off all their clothes as part of the exposure, and we often sort of struggle to get those things back on. So those are the really hard things, but the things that everyone has access to that I think make a big difference. There's really excellent evidence at this point that TXA is helpful. It's a small benefit, 1 to 2%, but it's almost certainly a real benefit. TXA, the evidence for TXA is the best within 3 hours of injury, and after that it becomes less. And that's sort of something we talk about at a lead trauma center. But for people seeing trauma patients in the periphery, they're almost always within those 3 hours. CRASH 2 used a protocol of a gram up front followed by an infusion, and 2 grams as a bolus is totally reasonable and often a little bit easier logistically. I think calcium supplementation is really, really important. Calcium is essential for a whole variety of parts of the coagulation cascade, and the citrate in blood will bind calcium. And so we give upfront calcium and amp every sort of 4 units of blood or every set of transfusion. But I think that there's not a lot, it's very hard to make a trauma patient hypercalcemic, and there's a lot of harm from being hypocalcemic. And so there's a bit of an asymmetric risk there. And I would, give calcium empirically and give it liberally. And then I think as you can target fibrinogen of greater than 2, that's helpful and something that often gets overlooked, but it's also challenging because fibrinogen assays take some time to come back. Not everyone has access to fibrinogen, but it's something that's really important. And then as Dr. Vogt mentioned, as soon as you can, reversing anticoagulation. That's a whole talk in and of itself. And so I don't think we're going to delve into that. There's a lot of great resources available online for that. But really, really important to identify if patients are on anticoagulation or antiplatelets and how to reverse that to the best of our abilities. Turn it over to Dr. Vogt.
Yeah, and I mean, I think we've alluded to this many times, but ultimately, many of the patients that we're talking about in this resuscitation phase are ones who are hopefully destined to arrive at our lead trauma hospital for that care that we discussed earlier. And in general, the aim should be to send the patient as soon as you can to the lead trauma hospital. That specifically includes things like advanced imaging, where if that's going to impair the time it takes for the patient to get to us, there is probably no role, given that it will not or may not be acted on in the center that it's undertaken. And there's nuance to this, though. speaking to a group of consultants, acknowledging that Orange doesn't show up the minute you snap your fingers and want them there. And so there may sometimes be time where that advanced imaging can be undertaken. That's a conversation that should occur with the trauma team leader prior to transfer. And that's really speaks to the next point, which is, because there are logistics involved in these transfers, the moment you think about transferring a trauma patient, that initiation of that phone call should occur so that we can start to mobilize the resources, both in the transport and also on our end at the lead trauma hospital, to receive these critical trauma patients.
And we're going to talk a lot about transfer. I think kind of the seminal work in this area is really relevant because it was actually done in Southwestern Ontario by one of my mentor and Dr. Vogt's mentors, Daryl Gray, as well as Paul Nicholas, looking at, there's a real emphasis on using air. And in critical care, we use air a lot. We use critical care paramedics. There's a real focus on safety and transfer. And I think that's really, really important. But the reality is that for lots of these patients, they're in situations where their definitive care, the thing that's going to ultimately save them, isn't present at that site. And while air seems faster, it's a helicopter, it should be faster than a ground ambulance. The reality is that's probably just not true. And Dr. Gray's work really identified that there was no distance at which point a helicopter will be faster on average than ground within sort of contiguous Southwestern Ontario. The reason for that is that if you look at it, and we'll use, for example, Meaford. So Meaford's really, really far from London. It's 3 hours away. But if a patient is in Meaford and needs to be transferred, ideally, the ambulance crew from Meaford is probably helping that resuscitation, is probably sitting there. And it's 3 hours on Google Maps at 5 p.m. It's probably less than that, lights and sirens. But hey, why don't we get a helicopter? The reality that we see and the reality that the evidence shows is that Orange is fast to fly, but the helicopter needs to take off, often from its base hospital in London or Toronto or wherever they are. Lots of the peripheral sites don't have helipads at the site or don't have helipads where they can land at night. And so that Orange crew sometimes has to land at the local airport and then transfer from the local airport to the hospital, drive to the airport, get the patient transferred into the ambulance to drive back to the airport, transfer them into a helicopter, which is no small undertaking, take the helicopter back to London, and then our heliport is right there. But even then, it's much faster to unload somebody from a land ambulance and drive them, 50 feet into the trauma bay than spooling down a helicopter and that process. And I think this is different. This is different than what we do in critically ill patients because they're in a place that's receiving critical care. They're on a ventilator. They're on vasopressors. They're safe. And then we don't want to transfer them without making them less safe. And in trauma patients, you have to recognize that the place where they are, while it has critical care, it has good doctors, it has people trying their best, it doesn't have the IR, the surgery, everything else that's needed. And so you have to accept a higher level of risk in terms of transfer by putting them maybe not within a critical care paramedic group, putting them with a physician and a BLS crew. And that's something that I think a lot of the TTLs really focus on and are happy to support people in making those decisions. I know I spend a lot of time talking about this when I have critically ill patients far away.
Yeah, and I mean, I think just to add on to what Eric's saying, we acknowledge it's not just about time, and we also acknowledge that the critical care paramedics provide a resource and that the human resources in the hospitals may not, easily be able to step away. But I think important to highlight this as a key thing in maybe the most severely injured patients where those issues should maybe take a backseat. And then I think the last thing around this is to talk about the concept of not all trauma patients will come right away. And I see some people on the call who I know have been involved in these cases where at the end of the day, because of the geography of Southwestern Ontario, and this is a Canadian problem in general, very sick patients will arrive in centers that are not trauma centers. And sometimes there is an indication for that patient to receive surgery in that particular center. I think it's tremendously important that those conversations are occurring early. And so we are working hard, both with our colleagues at Orange and policy change around notification of the unstable patient who's coming for transfer, but also in conversations with our centers that are referring us patients to talk about the possibility of advanced intervention prior to transfer. Realistically, this most of the time means a laparotomy for hemorrhage control in the abdomen, as really intra-abdominal management of intra-abdominal trauma is the purview of really any general surgeon. And so as much as it's an uncomfortable thing to do without the resources of a lead trauma hospital behind you, sometimes it's the right thing to do for the patient. And so sometimes these specific patients or conversations might occur where these patients end up in the operating room in centers that are a non-trauma center. And again, I know, that's happened, and certainly we've supported that. It's rare, but it does occur. And I think the other important thing to think about on the next slide, Eric, is that some patients within their goals of care and their family's goals of care may not be best served with a transport down to our center. And this is specifically for patients who have, at the outset, likely non-survivable injuries. Sometimes that's injury related, but actually more often than not, it's pre-injury comorbidity related. These are patients we frequently, unfortunately, frequently is not the right. We do get calls where we bring patients down with devastating brain injuries, with devastating thoracic injuries, who end up dying in very short order in our institution. And what we hear from families sometimes is that process of separating them from their families has been very difficult for the family, less so usually for the patient because they're too critically injured. And so this, there's a whole talk on this in terms of pre-injury conversations about end-of-life care, but you will hear our TTL sometimes push back around what are the goals of the family. And I would anticipate that some of these patients who are at the end of their life may enter your ICUs just simply for the care needs around the time of palliation. And that might ultimately be the best thing for them. So I do think that you're probably seeing that sometimes. And maybe a little bit more moving forward as our population continues to age.
We're going to talk now a little bit about traumatic brain injuries in the ICU and kind of in two spheres. The first is the emergent TBI patient that you may be involved in managing and helping manage with the emergency physicians on their way to a neurosurgical center. The points that are important are things I think that we would emphasize for everyone. But TBI patients are trauma patients first. And so the most important things when you look at research and evidence around outcomes is avoiding hypoxia and avoiding hypotension. And that means good critical care practices. Really, really important here is to reverse anticoagulation and antiplatelets. And there's lots of times where we say, oh, that's partial reversal. Does that have a benefit? I think where really you want to push for any reversal you can get is in a closed head injury, because a couple cc's of blood has been shown to make a big difference for some of these patients. Good ICP treatment in sort of the emergent setting are things like reverse Trendelenburg, but for many of our patients, they can't have that, head of the bed elevated, but for many patients, their TNL spines haven't been cleared, so reverse Trendelenburg works just as well. My own personal pet peeve is that C-collars do not need to be excessively tight outside of transfer, and that's a really easy thing to check so that it's not impairing venous outflow. Then the second tier is a little bit more medical treatment, but is important. So hypertonic saline for anyone with suspected intracranial hypertension. And I think this is used relatively liberally before imaging, and I think that's okay. The hard indications where it should for sure be given would be things like blown pupils or GCS of less than 8. Mild hypocapnia is beneficial for these patients. People talk a lot about hyperventilation, and really that should be reserved now for rescue therapy in those patients who are about to undergo decompression. And we'll talk about the evidence for that in a minute. And deep sedation does have some role here. There's the sort of really good randomized controlled trial for this is 30 plus years old now, showing that prolonged severe hyperventilation in patients with severe head injury is actually detrimental to their injuries. And so I'll switch tacks a little bit now and talk a little bit about the patients who are staying in peripheral centers, because I think we'd all agree that the patients on the right, if they're going to survive, do need to be in a center with advanced neuroimaging, advanced neurosurgical support, neurocritical care. But there's a whole spectrum of brain injuries. And I think that this is one of the areas where community general intensivists are taking care of trauma patients with isolated head injury. And so I think, the patients who need an ICU, a trauma ICU, are pretty clear. Patients with a GCS of less than 10 without any sort of other reason to account for that. any evidence of intracranial hypertension on CT scan, and those would be things like herniation, midline shift, compressed basal cisterns, or any mass effect. And then 100% if you are a polytrauma patient, that person is not appropriate for being monitored in an outside ICU. In terms of who can stay in a non-trauma or neuro ICU, we did reach out to the neurosurgery group to kind of make sure that we were on the same page here. I think patients with a GCS of 13 to 15 are appropriate, and who can be monitored clinically is really, really important. They should be clinically stable from a neurologic and other perspective. And one of the things that the neurosurgery group emphasized is that, especially in chronic subdural hemorrhage, the CT scan can look bad, but if clinically they're doing well, that patient may be appropriate for monitoring sort of as an outpatient setting. They have to have no mass effect. And then these patients should be discussed with neurosurgery, both in terms of upfront management, ongoing management, and then also the follow-up of those patients. I don't know if we have anything to add here, Dr. Vogt.
No, that's good.
If you have these patients in your ICU, some things that are important to talk about. And so general good supportive ICU care is important for these patients. Early enteral nutrition, if they're in your ICU, ideally they're awake and able to actually eat themselves even. Avoiding hypoglycemia is important in all patients, but really shown to be very important in trauma patients. So strict glucose control is not something we strive for. Trying to maintain a systolic target above 100 for patients 50 to 70 and greater than 110 for anyone else. I find this recommendation is from the Brain Trauma Foundation guidelines. It's hard to not put it up, but it is a bit clunky for sure. And then good care like fever avoidance with scheduled Tylenol, and then really avoiding hypotonic fluids. This is one of the instances where we actually do use a reasonable amount of normal saline to try and prevent hyponatremia as something that can worsen this. There's lots of talk, and we debate amongst ourselves as a trauma group in London about the use of seizure prophylaxis in traumatic brain injury. There's no doubt that putting someone on an anti-seizure medication will reduce their incidence of early post-traumatic seizures. And Dilantin or phenytoin probably has the best data. Levetiracetam is probably the best agent. It should, if it's going to be given, because there's no evidence that it improves outcomes in any way, it should be used for a course of 7 days, and this is what a lot of us use in London. And then repeat imaging is really the cornerstone of this. So a stat CT head should be performed with any change in neuro status, and that probably also needs to be discussed with the neurosurgeon who's been involved in the decision to keep that patient in an outside institution. And then most of the time, not all of the time, but most of the time, that patient will get a repeat CT head at 24 hours to ensure stability.
Thanks for letting me talk about this one, Eric. One of my very favorite topics of all time. I think, in general, trauma patients are at exceedingly high risk of VTE. And when we think about the highest risk factors, traumatic brain injury really sits right up there with multiple orthopedic injuries, pelvic injuries, and spinal cord injuries. So it's a real deal in these patients. And then I think the caveat to that is the treatment of VTE is also exceptionally complicated in the patient with a traumatic brain injury with blood in their head. So because of that, the importance of initiating VTE prophylaxis when it is indicated cannot be underscored. The initiation of sequential compression devices initially is of importance, and then this is a circumstance where that repeat CT head, it can be particularly useful. In general, no matter what the degree of traumatic brain injury, and as the amount of blood in the head gets more, the evidence supporting this gets less, but nonetheless, most conventional data supports that after 24 hours of stability on CT, VTE prophylaxis can safely be administered. In the most severe cases, sometimes a second CT is done 24 hours later, but practically speaking here in London, that's almost nobody. And we've been quite aggressive with our neurosurgery colleagues in building a protocol around this to the benefit of our patients and decreasing their risk of VTE. So think about it early. If that initial CT looks stable, then I think go ahead and institute it. So you're not trying to figure out how to safely fully anticoagulate someone with a recent traumatic brain injury.
So lastly, I want to talk a little bit about something that's kind of one of my sort of key things I like to emphasize is that the reality is that in peripheral ICUs, there's not a lot of patients ending up in these ICUs that are polytrauma injured. That's the way our system's designed. But when someone has an arrest from a non-traumatic mechanism, we exert trauma upon them And patients who have multiple rib fractures in the lead trauma center, they get targeted assessment pathways. There's comprehensive multimodal treatment plans that have been developed, and we've done some of the work in this area. They get dedicated physiotherapy. We keep exceptionally close watch over these patients for the complications that can be associated with increasing rib fractures. And often patients with multiple rib fractures from CPR get some of that maybe, but not in any way near the protocolized fashion. And so I don't think that every patient with rib fractures from CPR needs to be treated like a trauma patient, because the reality is that the underlying pulmonary contusion probably isn't there. But I think that when you have the instances where you see your patients with CPR-associated fractures are suffering because of it, by far the best data for those patients is going to come from the trauma literature, and something that all of us can take forward. And you can't tell me that someone that has a floating sternum from a really beefy, strong ED nurse or ED tech, or a really, vigorous nurse on the floor whose their sternum is disassociated from their ribs, doesn't benefit from having good care of those underlying injuries as you go through the weaning process. And so I think the things that are important to think about are that, we know from the literature that traumatic flail chests have much worse outcomes. We know that they have more pneumonia, longer rates of mechanical ventilation, and that for every fracture, they have worse outcomes, and taking that forward. There isn't a lot of research into CPR-associated rib fractures, but there's a couple of studies starting to come out, a lot out of the Chest Wall Injury Society, that shows that this is associated with poor outcomes. Again, not in every patient, because lots of patients with arrest have other problems, be that medical, be that neurologic. But the patients who are doing well otherwise, you fix their underlying cause of arrest and their brain is intact and you just can't get them extubated. This is where I think there's value here. A lot of this is taken from the pain management guidelines from the Eastern Association from Trauma. This is sort of our pain management ladder in London. And I think that the key is that we start with regular scheduled Tylenol. Tylenol is a safe medication. It's not going to fix the pain from these rib fractures for everyone, but it provides the base of the pyramid. Using NSAIDs, if they're not contraindicated, is really, really effective. I think they're probably the best medication you can provide. They're just limited due to things like age and bleeding risk and kidney function for sure. But when able, they're something we don't often reach for. And then there's a whole bunch of adjuncts we can talk about. So the first thing is to ensure their pharmacologic strategy is optimized. So we talked about Tylenol, we talked about NSAIDs. Gabapentinoids sort of have mixed evidence in acute pain now coming out of the trauma literature. They are probably associated with increased delirium, but can be used, especially if a patient is on it at home. Cannabinoids, so nabilone, is starting to be used a lot more from our colleagues in the acute pain services and can be effective. And then again, similar to gabapentin agents, if the patient is taking a large amount of THC at home, putting them on some nabilone and supplementing that can be quite helpful. Things like pain dose ketamine or dexmedetomidine infusions do have reasonable evidence and can, our whole goal here is to minimize the amount of opioids that someone uses. And then we have a really good experience in London with using lidocaine infusions. The evidence isn't there yet to say that it's for sure beneficial, but it is safe and something that we use quite effectively. And then I think really the mainstay of the patient who's really, really struggling should be involvement of your anesthesia colleagues to talk about regional anesthesia. Epidural, paravertebral, intercostal nerve blocks, they all have evidence. They haven't really been compared heads up to each other yet. But it's, a really effective epidural can make a big, big difference for these patients. And then if you weren't already considering non-invasive for post-extubation support for these patients in a protocolized fashion, this is a patient I think it's worth talking about. And then lastly, I think it's important to talk about rib stabilization surgically. This is something we're starting to do more and more for trauma patients, and it's an ongoing evolution. Who benefits, who needs it, who doesn't. In London, this gets provided to patients who are really failing a ventilator wean associated with multiple rib fractures. And it can be quite effective. We have lots of stories of patients who were extubated once, twice, 3 times and failed, and then they stabilized their ribs and they got better. It's been reported for CPR-associated fractures with failure to wean. It's never been studied in any sort of rigorous way, but I hope that this is something that gets looked at more. And I did reach out to our thoracic surgery group in London so that we have some local context. And while they said they haven't had a lot of experience with this, they would absolutely be happy to take a call about someone with a central flail who's struggling to get off the ventilator and to talk about whether rib stabilization would work for them. One of the nice things is that requires a CT scan that will be available for them to visualize, and they can say, okay, I think this is someone who may or may not be amenable technically, and then you can have that conversation. So again, this is very early days in this treatment strategy, but just to put a bug out there if you have a patient who fits in that category. And that's kind of all we have. We tried to leave a reasonable portion for questions at the end. Obviously, Dr. Vogt and I and myself as well are happy to take any questions for anyone out there.
Thanks a lot, guys. There's been no anonymous questions sent, and in the chat, there's just been some comments. So Dr. Tanasia mentioned, you know, a 20-minute chopper ride has the same emissions as a car on the road for 2 years. And just so everyone's aware, our next speakers are going to be 2 Orange physicians, and you know, maybe they'll be able to comment more about that. And then Dr. Helt had mentioned, you know, rector spinal blocks are an effective way for rib fractures to help people breathe a little easier and hopefully try and get them not intubated. You know, the other one that could be done is intercostal blocks, which are helpful. And then here's Dr. Leeper chiming in with Tesla helicopters. But I'll leave it for any questions from the group for now.
Hey, can you see me okay? Hey, Anton, no, I just, I really only had just positive comments to offer, nothing really incisive or clever to say, but it was a great talk, and I do agree with Ravi. We need obviously battery-powered helicopters to fly our patients around. I'd buy one for sure. And I think it's interesting that we heard Dr. Helt give his pitch for pain control, because of all the folks that I kind of see admitted who've already had like hyper early thoughtful pain, and actually that often the ones we get from Dr. Helt are on ketamine drips, already getting like early rib blocks given. And I almost wondered, or wanted to put out there, like, how soon should we be looking to provide that level of advanced pain management from our rib fracturations? Because we probably get lidocaine started as early as we can, but that means when they get up to our trauma assessment unit, not in the emerge. And like, is there a role for like even prior to getting to ICU to start this stuff? I don't know what the data is on that. I wonder if Eric or even Andrew wants to chime in and give us their thoughts on kind of how early can you start adjunctive pain management stuff for chest injuries, and how do you operationalize that in a trauma system?
I'm happy for Andrew to speak up, because I know go ahead.
I don't have a ton of I suppose evidence to say how early is optimal. I do think about it often about one, when is the right time, and two, how as a trauma system, both in London and in the community, wearing my 2 hats, is the right or would be the best way of doing things. Obviously, part of it is knowledge about the options that are available, like lidocaine or multimodal pain management or nerve blocks and the like. And when you have the tool, like a group of nurses that are very comfortable and used to setting up lidocaine infusions, or you know how to do a quick and easy nerve block, I think it's a lot easier. And so some of it might be just education in terms of actually being able to do it. And then as you're expanding the number of people who are able to do it, then it becomes a culture shift, and it happens more often. But in terms of when is the best time, I think any patient in pain deserves to have their pain optimally controlled. Whether or not that translates to changes in mortality or morbidity, I have no idea.
Yeah, I don't have much more to add. That's really good. I know from the literature, from reviewing this for a couple of things, that, you know, I think lots of these treatment strategies have been compared versus standard of care, which is usually multimodal, hopefully analgesia, and they always show benefit. Unfortunately, there's not as many studies comparing all the different ways we can provide regional anesthesia with each other, because I think that would be helpful, but probably also hard to show a difference. And so I think that but to the comment about when, I think earlier than we probably do, although unless you're someone like Dr. Held who's really good at this, and especially in sort of looking at a general systems ICU group, I think it's hard to do that really early because there's a cardiac arrest that just happened and there's neuroprognostication that often needs to happen, but just trying to think about it as early as possible, and sort of in a tiered approach in terms of what we're going to do. I quite frequently, whenever I have someone with CPR-associated rib fractures, at least do all the multimodal things right away because it's easy and it's often really helpful, and then probably start to not wait till they're failing the third time before looking for regional help. There was a question from Eli I saw.
Yeah, hi, thank you. Eli Malice, the Regional Critical Care Lead from Mary St. Clair. Just a quick question around early DVT prophylaxis. Agreed, certainly it's sometimes a little bit of a battle with neurosurgery, but in spinal cord injuries, non-completes, how do you address that early DVT prophylaxis?
Yeah, thanks for that question. I will take that unless you want to, Eric. Really similar. So, there's been a whole process of education with both our neurosurgery and spine colleagues, and it wasn't a quick fix to kind of change some of these policies. Really, the evidence around spinal cord injuries is much less pervasive than the traumatic brain injury, which I think we have fair safety data in. So it is a conversation. Presumably those patients have undergone surgical stabilization, and typically we are holding up about 48 hours in those patients before initiating VTE prophylaxis. There's no, in the absence of, surgeon concern and desire to re-image, there's no routine imaging that's occurring prior to that. We used to hold off 5 days, and so we're just kind of slowly backing back a little bit. But if they have good hemostasis, they're generally allowing us to do it at 48 hours. And I think if it's a non-operative, I would say that the same strategies would apply.
Thank you.
I guess if nobody else has questions, I'll ask one. So I find this all very interesting of keeping, trauma patients on the periphery. Do we have any statistics on the Southwestern region of how many trauma patients are kept down on the periphery and what patients are those and how we compare to other regions?
Yeah, it's a great question, Anton. The answer is no, we don't have any data. We have tried in various ways. For those who don't know, I'm a big researcher. So we've tried in various ways to sort of estimate this. We can do it a little bit on a provincial level when we look at some of the reporting. But as you know, even what we report out to CIHI is not particularly specific when it comes to traumatic injury. So there's no great way to identify who actually meets the criteria for trauma patients. What I will tell you, as I alluded to before, like one of my favorite parts of my job is going out to our referring hospitals and kind of chatting with them. We run a regional trauma team development course that sends us out, and we do simulations in the emergency department, and you get an opportunity to talk to people. And what I know from that experience is that there is a real shift. When I started my training more years ago than I would like to count, Rob and I started in the same year. I think it was much more common to see the moderate but not severely injured trauma patient managed in a regional center. As time and other pressures have advanced, I think that we're certainly seeing more calls for transfer of patients that we think previously were being managed in the regional centers. So I think there's a decline over time, though I don't have a ton of data to support that. And I think the reasons for that are really complex. That being said, we do know that there are certain hospitals in our catchment area that have a preponderance for holding on to trauma patients, probably to their benefit. And this is being recognized provincially, actually, with the development of what are now being called level 3 trauma centers. We don't actually have any of those yet in Southwestern Ontario, but I anticipate that there are a few hospitals that will kind of go down that path along the lines of the Guelphs and the Barries of the province, who say, you know what, we really do actually have, we're already doing this, and maybe some resources to help us support the care of these patients in a bit more of a regionalized way would be useful. The advantage of that is that it comes with a data collection. First of all, funding to support data collection, but second of all, allows us to better understand the movement of trauma patients in the province. So hopefully that's coming in the not too distant future for our region.
Yeah, I just wanted to double click on what Kelly said, because Anton's question, I think really what it's striking at is who are the right patients to keep and where are the right places for them to stay. And I think Dr. Vogt's got it exactly right. The idea that there are not every peripheral referring hospital is created equal, and there probably are some that are higher level centers. I just was thinking of an anecdote from just the other week where, you know, somebody had relatively isolated chest injury but needed a chest tube and had a hemothorax, and because they happened to be in Woodstock Hospital, where one of our trainees, Jeff Metz, was on call, I thought that's a great person to keep there. And Jeff called me the next day and we talked a bit about it, and it worked really well, actually. I think, you know, I hope it did okay. I didn't get a follow-up, but I think Dr. Vogt's right. There are places that are kind of more, if the term is level 3, sort of capable. And one of the big hallmarks of that is places that have like full-time committed surgical services. That's probably a good sign that hospital is built with a decent sized ICU, a closed ICU, with surgeons who are there all the time and can manage issues. Those are great places to keep single system patients and get great. I think they get great care. That's sort of if, you know, knowing backstory on where we're going with verification and leveling of centers, that might be a big win for our regional trauma system if those become more recognized and more supported in our system.
That's awesome. I'm just going to give another minute to see if anyone else has any questions, and if not, I'll start wrapping things.
Maybe, Anton, while we wait, we can just plug again, talk about sort of the next step for SWOCCS.
Yeah, actually very much in line. We're going to be talking about transport the critically ill patients. We have Mike Peddle as well as Mike Lowell, who are Orange physicians. Maybe they can ask some of Dr. Taneja or answer some of Dr. Taneja's questions about gas usage. But also there are some updates about blood transport, and I'm sure there'll be a lot of questions about how to get patients to different spots around our region. So have those questions ready. Again, please use the form that I posted in the chat to ask any of those questions ahead of time, give them some prep. Unfortunately, we don't have a date yet available, but look for invitations going out in the next month, and it will likely be in May or June.
And that just reminds me, I meant to go back to this too, just to let everybody know, there is a study starting in the province of Ontario in the next, it's not entirely clear, but in the next month or two, looking at whole blood in transport. So just so everybody's aware, if Orange arrives in your institution for a modified scene response, they may in fact bring with them whole blood. There's no expectation that will never be run in your centers. That's an issue for us, but you may see it. So having just heard from us, it's not available. Canadian Blood Services has released it for investigational use, and we are participating in an international trial. So it'll be the Toronto-based helicopters that are carrying it. So we see them sometimes, not as often as our London-based helicopter, but it is coming, just to put it in everybody's ear.
So if there's no other questions, maybe we'll close it out. So we'll see you guys in May. Again, we welcome any opportunity for questions or feedback or comments. We are going to take a break for the summertime, and then hopefully come back in the fall with a full slate of what we hope are useful, both useful practical lectures with excellent speakers like Dr. Vogt came and did for us today.
Thank you, guys.
Thanks for having us.